In urologic trauma, massive kinetic energy enters the pelvis, but the internal bleeding that follows rarely spreads randomly. Instead, the fluid hits invisible walls, creating highly constrained, predictable patterns of hemorrhage. A direct blow to the perineum might result in a highly localized, superficial swelling isolated to the scrotum, but apply the exact same mechanism of blunt force slightly deeper, and a patient can present with a massive pelvic hematoma displacing internal organs entirely out of position. In this cross-section of the male urogenital tract, glowing structures reveal inelastic fascial planes, Colles fascia, Buck's fascia, and the tunica albuginea. These tough layers form absolute physical boundaries. During a traumatic rupture, they act as rigid containers, trapping blood and urine in isolated compartments. By reverse engineering the shape and location of the visible swelling, clinicians can deduce exactly which internal structure failed and identify the fascial container holding the leak. This structural deduction determines the exact sequence of emergency diagnostics and the immediate surgical intervention required to save the patient's function. In the lower pelvis, anatomy is the absolute blueprint that dictates the limits of pathology. In this sagittal view, the urethra divides into proximal blue and distal orange zones. Anterior injuries often occur through a straddle mechanism. The bulbar urethra is violently crushed against the pubic symphysis. Escaping fluid quickly hits Colles fascia, pooling strictly within its confines. On physical examination, this fascial containment presents as a classic, isolated butterfly-shaped hematoma, restricted entirely to the superficial perineum and scrotum. Proximal urethral injuries present an entirely different diagnostic picture. These tears are almost exclusively the result of high-velocity crush injuries, like major motor vehicle collisions. Notice what happens as the pelvic ring fractures. Massive shearing forces snap the rigid membranous urethra right at the urogenital diaphragm, severing the puboprostatic ligaments. Without those fascial anchors, an expanding hematoma fills the pelvic cavity. The untethered prostate gland is forced violently superiorly. This leads to Vermeuten sign. During a digital rectal exam, instead of feeling a firmly anchored prostate, a physician palpates a floating, high-riding, boggy mass. This brings us to the golden rule of urologic trauma. If blood is visible at the external urethral meatus, blind Foley catheterization is strictly forbidden. Forcing a catheter blindly into a partially torn urethra will bore a false passage straight through the exposed tissue, causing a permanent stricture. Instead, clinicians must perform a retrograde urethrogram, injecting contrast dye under fluoroscopy to map the exact location of the extravasation before any physical intervention occurs. The visual boundaries of the swelling instantly tell the surgical team whether they are dealing with superficial tissue damage or a deep ring failure. The architecture of the erectile bodies relies on distinct pressure systems. The ventral corpus spongiosum expands at a low pressure to protect the urethra, while the paired dorsal corpora cavernosa engorge at significantly higher pressures. This transverse cross-section identifies the physical mechanism of that high-pressure system, the tunica albuginea. It is a thick, highly resilient, but entirely inelastic bilaminar sheath encasing the cavernosa. A penile fracture occurs when a fully rigid penis is subjected to an abrupt bending force. The extreme pressure violently overwhelms a tissue's tensile strength, and the inelastic tunica albuginea transversely ruptures with a distinct snapping sound. The erection is instantly lost. High-pressure arterial blood rapidly escapes the tunical defect, flooding the superficial fascial planes to create the classic eggplant deformity. This is a true urologic emergency, requiring immediate surgical exploration. The hematoma is evacuated, and the tunica albuginea defect is sutured closed. Failing to restore this pressure container guarantees long-term erectile dysfunction. Similar mechanical principles applied to priapism, a persistent, unwanted erection lasting longer than 4 hours. The delayed outflow creates a dangerous compartment syndrome. This microvascular diagram shows ischemic priapism. The venous outflow tracts are completely blocked by sludged red blood cells, trapping stagnant, deoxygenated blood inside. The resulting hypoxia is agonizingly painful, revealing dark, acidotic blood. In contrast, high-flow priapism follows blunt trauma, creating a fistula. Here, oxygen-rich arterial blood dumps continuously into the chamber. Because venous outflow remains open, the tissue stays oxygenated. For the ischemic variant, intervention must be immediate. Clinicians aspirate the toxic sludge directly from the corpora and inject potent vasoconstrictors to clamp inflow. Whether it is a tunical fracture or a blocked venule, these emergencies represent crises of extreme hemodynamic pressure trapped within unforgiving biological constraints. Inside the operating room, recognizing these precise fascial layers and anatomical landmarks becomes the sole barrier preventing severe iatrogenic injury. In this endoscopic first-person view of the proximal urethra, a small elevation called the verumontanum serves as a critical boundary. During a prostate resection, surgeons aggressively clear tissue, but the verumontanum dictates an absolute hard stop. Resecting any tissue distal to that landmark destroys the external urethral sphincter complex. Once severed, the patient is left with permanent urinary incontinence. This reliance on rigid physical borders also governs urologic oncology, particularly in the surgical management of primary squamous cell carcinoma of the penis. To safely excise the tumor without recurrence, surgeons must achieve a microscopic clearance, which currently demands a 0.5 centimeter macroscopic margin of healthy tissue. If that strict margin leaves at least a 2 centimeter functional penile stump, allowing the patient to direct their urinary stream, a partial penectomy is viable. If the anatomy won't yield those 2 centimeters, a total penectomy is medically mandated. This map traces the lymphatic vessels to show the most critical prognostic factor for survival, the involvement of the deep inguinal lymph nodes. Advanced penile cancer rapidly infiltrates this lymphatic chain. As metastatic tumor growth expands within the nodes, the tissue becomes severely necrotic. Eventually, this necrosis erodes directly through the walls of the adjacent femoral or iliac vessels, resulting in catastrophic, uncontrollable exsanguination. Whether preserving an internal sphincter or racing ahead of a lymphatic invasion, success requires acknowledging the absolute physical limits of the patient's anatomy. The male genitourinary tract operates as an intricate network of high-pressure fluid dynamics, tightly regulated by rigid fascial containers. The clinical signs of urologic trauma are never arbitrary. They are highly predictable mechanical readouts, signaling exactly which anatomical boundary has failed. These 3 icons summarize the diagnostic logic of pelvic trauma. A perineal bruise marks the limits of a fascial container. A blood gas reading measures the failure of an internal pressure compartment. And a floating prostate confirms a severed ligament. Miscalculating these physical indicators, forcing a catheter through torn mucosa, or cutting past a safe margin results in immediate, irreversible harm. Mastery of the urologic pelvis requires the surgeon to navigate these strict structural thresholds. Recognizing the problem requires visualizing the unseen fascial walls buried deeply beneath the swelling and the bleeding. In high-stakes urologic intervention, knowing exactly where the anatomy stops is the only way to ensure the patient's recovery can begin.